everybody. Good morning, everybody. Today is August 8th. It is Father's Day, and I wish all the fathers here have a very nice and happy Father's Day. And we know that 3D surgical simulation is the core value in our craniofacial research team. And today we are really happy to have Professor Lo to talk about the 3D surgical simulation of orthodontic surgery, a team approach. Professor Lo, would you like to start?
Yes, thank you, Dr. Kirk. This topic actually is I presented several times before, but I would like to present it again so that we have some over and over we have some modification in terms of how we do the 3D simulation. And I believe that every one of you have a different idea how to do the planning in the 3D image. However, I think from my personal perspective, I'm a surgeon, so that I will particularly look at the so-called the physical part in the simulation. Is there any difficulty in terms of the surgery, or is it any reliable fixation using this kind of design or not? So this is actually in every case we will have discussion between me and orthodontist and also my research assistant. And I think we should actively use this kind of software, and possible we also have 3D printing facility in our lab. So if you find that you have any wish to do something else, please come to the image lab. There's some resource that you could use in order to improve your planning and also possibly surgical execution. So下一张要怎么用？相助。Oh, okay. First, I do not have a conflict of interest to declare. And this is, I always appreciate Professor Chen's initiation of this research center that allow us to have a large group of multidisciplinary team to work together. And also we have the software, hardware, and also research project in this research center. And below the photo is one that I always use to show that for every case we will be in the small meeting room and discuss each case together between surgeon and orthodontist as well as a research assistant. And I found that over and over we have gradually improved our research, our surgical simulation. We mentioned this paradigm shift recently, that almost all OGS, they are now using the 3D simulation rather than conventional planning. Certainly, conventional planning, the idea, the data, cephalometric data, still in our preliminary planning, and then we go further using the 3D image. But this so-called basic the normative data actually is should always be kept in our mind when we do the planning. And also Lun-Jou surgery has become more and more popular in our team. Perhaps more than 95% of the cases we do Lun-Jou rather than Wan-Jou. We can achieve not only the occlusion but also the facial aesthetic. I think that this is maybe the most important point why we do Lun-Jou surgery rather than Wan-Jou. Also, double spring or single spring, and also is still controversial. And I believe that in other center or team, double spring is still the standard way, but we also use single spring in our team. I think it's depends on the surgeon's preference and also their individual situation. You should shift the double spring to single spring. And also CAD/CAM facility is actively used nowadays in the planning of the orthodontic surgery. And certainly 3D printing is very helpful, not only for occlusal spring, but also for physical model. And also you can have some kind of modification if you feel that any additional part using the 3D printing, that could improve the 3D planning. I think the advantage and disadvantage of single spring technique, and certainly, as I mentioned, that it depends on the surgeon's preference. But personally, I feel that if we do single spring, it's easier to set the maxillomandible together, and then we mobilize the maxillomandibular complex, we call MMC, in the operation, and then adjust the position until this is the most ideal according to the plan and according to your subjective evaluation before you do the plate and screw fixation. And certainly for some facial asymmetry case, it is more convenient because then you don't have to struggle to mobilize one jaw to the desired make the judgment. You don't have to make the judgment a lot, and you just go step by step. And I think it is easier for education using the double spring. And further, double spring can control the pitch rotation. Perhaps this is the very important point that argue the double spring is surgeon. I think double spring is an easier way. However, if you feel convenient and you are more experienced, you can certainly use the single spring technique. This is the image lab that include the data resource, the hardware and the software, and certainly we're using a lot Dolphin and previously Simplan, or most recently ProPlan. That is all useful for the surgical planning. And also we also need to use other software to do in the planning process, such as setting up the occlusal spring image before the printing. This will require other kind of software. We have a data storage device or facility in our lab. I think this is a very useful and important part in our clinical as well as research practice. I think this data storage, the main important part is the 3D data, because 3D data is a very huge data set that we have 3D photo and computer CT or 3D laser that require a large facility to store this data. And since the center established 12 years ago, this hardware become aging. So I thank you, Professor Ray Chen, that used his research fund to renew the data storage device. And we also had 3D printer in our lab, and also one in our school that could be used. And I mentioned further that clinical engineer, because in the recent practice of the orthodontic surgery, if you are a busy team, busy center, I think you must have a clinical engineer, because this could bridge the gap between the surgeon and also the practice, because there are many software, hardware that you do need a specialist to support, to facilitate this process, and also to teach us how to use, if you have an idea, how to achieve that final goal using the 3D technique. Certainly, this clinical engineer is important in the team, and also the assistant, clinical and research assistant, also is important in the team. And this is just I mentioned this before, that you can use the 3D imaging in both clinical purpose as well as the research purpose. And I will not describe it in detail. And so how do I do the 3D simulation? This is a case of 18 years old bilateral credit and palate that we just maybe 1 month ago, we did the simulation and we finished the operation as well. Just want to show you what is the process that we do the 3D simulation. And of course, first we show the patient's photo, frontal view, basal view, and the lateral views, and to see the symmetry, the occlusal relationship, and also to see the facial profile. And then we design the default one osteotomy. You can see here the how to define the default one osteotomy line. So you may also use so-called positioning guide or osteotomy guide, or just simply use this from the U3 or U6 to the lateral pillar or medial pillar, and then you decide the 2-point, then subsequently you define the default one cutting line. It's important to follow the same cutting line as you plan. Otherwise, the movement in the default one level may not be accurate. So this is also an alternative way to define the default one cutting line. And also start from the frontal view. This is the this is the Dolphin software, and you can see the distance from the occlusal plane to the FH plane between U3, U6, and also between the left side and right side. And then the first step is to set up the final occlusion, and this will form the maxillomandibular complex. and then we mobilize the MMC according to the initial treatment plan from the normal cephalometric data, and then we do the modification based on the symmetry, based on the the proportion, based on the aesthetic concept, and also based on the surgical feasibility. So we may go several times to set up from the plan and to the final modification. And then the lateral view, the same. We just you know, from the first frontal view, and then I move to the right lateral view, set up the final occlusion, mobilize the MMC, and then to modify and to finalize the 3D plan, and then go to the other side to see the step 1, step 2, step 3, which involve multiple procedure to have a final MMC plan. And if I feel that this is the ideal facial aesthetic position of the MMC, and also its surgical possibility is okay, then I would you know, find agreement between in the treatment team. And then the basal view here, and to see the occlusion and then treatment plan, and then do the adjustments so that the symmetry from both sides is obtained. And also to look at the maxilla here, the so-called the PMJ, the pterygoid maxillary junction, how much advancement here, or sometimes we do setback, and then how, or do you find the so-called the collision, the skeletal collision between the maxilla and the pterygoid plate. And this show the data in the ANS, PNS, or A point, B point, and or the U1, the incisor, because I think the incisor show is important that, for example, you see that this U1 incisor show vertically, it is impact the up for 1 millimeter, and left, also the left right shift to adjust the U1 midline, and also we have this so-called AP position, and this U1 is moved forward for 8 millimeters. So this data set is for our team to have reference when we mobilize the MMC. And for example, if you find that this mobilization is more than 7 millimeter, that will be a major advancement. Do you need any adjustment in terms of the advancement, or you can move it backward a little bit so that it's easier, or to reduce the relapse possibility? And this all has to be agreed in the team when we finalize the treatment plan. And then this is the default 1 advancement amount, which is okay in terms of the surgery, the 6.8 in the right side, and 7.4 millimeter in the left side. And then this is the impaction or lengthening. In this case, it is not very much. So after the default 1 osteotomy, we will focus on how much do we advance, how much the dissection should be performed to mobilize the maxillary segment forward for 6 to 8 millimeter before the fixation. And this, I look at the lateral profile view. I would see the amount of setback And also this may be the amount that I have to resect the posterior part, minimum 4 millimeter, in order to reduce the backward position, to reduce the soft tissue resistance, and also to reduce the muscle attachment, the medial pterygoid muscle, so that reduce the distal segment is more free and release and mobile. And also here, look at the genioplasty advancement, and how to create a good chin position. And the other side, and this I have to reduce at least 5.7 millimeter in the back. So certainly in the surgery, I would reduce a little bit more than this amount. And I also look at the so-called the nerve canal, the inferior alveolar nerve canal, its position, so that when I do the posterior cut, I should be careful not to violate or not to injure the inferior alveolar nerve. And then I decide which jaw that I should go first. And in this case, I found that the maxilla first is easier. I'm sorry, this maxilla first may not be a good idea in this case, because of the larger advancement, and also I look at the maxilla maybe weak. So I would prefer to do this mandible first, because if you look at this maxilla first or mandible first, to produce a occlusal spleen, actually the first intermediate occlusal spleen, it seems that is the same. And I found that if I do the mandible first, the fixation may be more stable, rather than I do the maxilla first, because the 7 millimeter of advancement plus the maxilla look weak. So when I manage, if I do the maxilla first and I manipulate the mandible, that could to move the fixation plate and screw. So in this case, I choose to do the maxilla first, because I found that it's either way, the occlusal spleen is easy to make and easy to fit during the surgery. And certainly this is the final, and again look at the second spleen to design the occlusal spleen as a final spleen. And in my practice, I would like to use this extension bar, and this extension bar help me to determine the midline, and also the occlusal plane for the roll rotation, and also the vertical part for center line. And I also like to see from the lateral view, and that I could decide to check the pitch rotation that could make it more accurate when I do the pitch rotation. And then this is also an important view for surgeon. And if you look at the left inferior, you see the PMJ, pterygoid maxillary junction. When I insert the Kawamoto osteotomy, I know how I go posterior and back and medial to accurately feel the PMJ before I use my hammer to disjunct the pterygoid mandibular junction. And also the left upper, I define the entrance of the inferior alveolar nerve, so that I will find out where I should use my 3 millimeter burr to cut the medial osteotomy. How thick the mandibular ramus here, that I could use the So here I could use my 3 mm burr to burr the inner cortex above the entrance of the inferior alveolar nerve. And also here is the junction showing the PMJ here on the right right inferior view. This is usually we insert our Kawamoto PMJ osteotomy, and certainly this show uh, the level of the inferior alveolar nerve. It goes below the mental foramen, and how anterior it goes before it turns up and out as a mental nerve. So this also is quite important information when we perform the genioplasty, and not to injure the inferior alveolar nerve. And certainly in this case, if we use the so-called traditional standard 5 mm below the mental foramen, and you could have possibility to injure the inferior alveolar nerve before it's exit from the mental foramen. And I also would very much look at the inferior alveolar nerve inside the ramus. This on the right side is quite so-called typical presentation. It's in the inner cortex, so it's easier for surgeon when we do the BSSO split. Your osteotomy is quite, in the safety margin, far away from the inferior alveolar nerve. And also in the left side, it's a bit in the middle. Uh, uh, Certainly it's more inside, but part of it is in the middle. So when we split the BSSO, be very careful not to injure. We may open the window and then look at the nerve, and then pass the nerve when we do any kind of manipulation in order to separate, to split the ramus. And then look at the airway, and this is I learned from Dr. Lin that in the design always include the airway in the plan, so that when we do the setback of the mandible, this is a good reference. Okay, this is so these are the typical from the beginning to the end in my plan. So I would create a PDF file and send to my team. And this is our plan, and also we can review this plan before the surgery. And if there anything wrong, we can make the adjustment, or we can change the plan. This is a very interesting case, maybe not the only one case that has a very long distance. The inferior alveolar nerve go inferior from the mental foramen, and in this case, it is 8 mm on the right side, and it's 11 mm on the left side. So it is extremely dangerous if you do the genioplasty. Of course, you can design your genioplasty in other fashion, so that you don't injure the inferior alveolar nerve inside the mandible. So this preoperative assessment using the 3D image certainly give a good better safety before you send the patient to the OR. And then so this 3D simulation process is basically a computer assisted orthodontic surgery, and we can use it for evaluation, planning, simulation, production of occlusal spring, and also to make positioning guide, or to do navigation, and finally to do validation. So for clinical purpose, for research purpose, you can do anything you like. Okay, so that's why I said that you do need research assistant, you do need a clinical engineer, because there's something else that you need to some specialty to help you out in the process. And positioning guide navigation is the previous, we do this. We no longer routinely do this, but if you find that there are some special cases that is, you better have this support, then you can come to the image lab to do this. And I think this is the same process to do the same initial process before the navigation in the OR. Then we use this brand lab and so-called the navigation bar, navigation pen, and also the tracker here. And this is the design of the positioning guide. This is for the 4-1 positioning and fixation, temporary fixation, before you do the final fixation. And this is the process of producing the positioning guide using another software. And then you can, for each individual patient, this positioning guide is different, and sometimes also different in the design process, because patient had different bone morphology. So this is the so-called custom-made positioning guide. And we drill the hole. This is for temporary fixation. And you can check the positioning guide by producing the physical model. And this is the previous cases using to use the osteotomy guide and the positioning guide. And after temporal fixation, you can retract the soft tissue and have a so-called assessment, subjective evaluation for the symmetry, for the proportion, for the tooth show, before you do the final fixation. And then remove the positioning guide, and then do another plate and screw fixation. And if you wish to do navigation before the surgery, you need to go to the lab, spend an hour, and to determine the registration point, and determine the 4-1, and also determine the validation point. And this is important process. So that's why you need to take extra time to in the lab to prepare this so-called registration point. And then in the OR, you have step 1, 2, 3, 4, 5, step by step for the to do the reference star, and then registration, verification, and then do the surgery and surgical navigation, and then to finally check the MMC position. So this is the just quickly show you the preparation in the lab, and then navigation in the OR 5-step. I think if you're interested, you can read the reference paper. One case, facial asymmetry. This is actually a hemifacial macrosomia that we used planning and set up the navigation plan. And this is the case before and after surgery. And then we also create a composite occlusal spring that's for the intraoperative verification in a single spleen orthodontic surgery, and you can compare this. In this same patient, we have both conventional occlusal spleen and the occlusal spleen with extension bar. And certainly, to myself, I feel that it's provide more information to judge if the maxillomandibular complex is in the right position or symmetric position before we perform the fixation. And this is the case using the extension bar occlusal spleen, and we don't need to retrap the skin in order to check the position, just because this extension bar is slightly out of the mouth opening, so that we can easily check the position of the maxillomandibular complex. And then to produce the occlusal spleen using another software. And this is the final occlusal spleen, and then attach the extension bar. This is several extending part for horizontal, for vertical, and for midline evaluation. And I particularly like this extension bar for so-called to control the pitch rotation of the maxillomandibular complex. In my previous practice, I found that it's difficult for me to have very accurate control of the pitch rotation when we perform the class 3 occlusion cases, prognathism cases. So this, if you patient lie on the table and you determine the FH plane, and you need to position the maxillomandibular complex and also the extension bar, that is 90 degrees to our FH plane. And so this provide additional checkpoint. How if you have accurately perform the pitch rotation, the clockwise pitch rotation. And this shows the case during the fixation and with the extension bar, and also the skin horizontal line. This is corresponding to the skeletal FH plane. So this is the 90 degree of the extension bar with the FH plane. That shows that the pitch rotation is accurate in this case. And so also can use Facebook and with the extension bar to check the midline. And this is the patient before and after surgery. That shows the midline and also occlusal plane and facial proportion before and after. And also we can use this 3D plane if you wish to correct the symmetry. Sometimes we need to maintain the space between the segment in the ramus. That means that we do not approximate the proximal segment to the distal segment, and we need to separate for additional 2 or 3 millimeter for the bicortical screw fixation. Then you need to keep the space. Then you can design so-called design a spacer during the fixation. So this is a case that I designed the spacer. I use the spacer to hold the 2 segment in the ramus separated, and then do the bicortical screw. After the fixation, I remove the spacer, and then in this case, you can see in the left side, I could maintain the volume without being smaller than the right side. And also I can make so-called the one side occlusal spring. In this case, our plan is to do the segmental osteotomy in the maxilla, and I wish to do additional immobilization of the maxillary segment. So I designed a one-side occlusal spring in order to immobilize the central segment with the lateral segment. And this is the one-side occlusal spring, so-called the third spring, not the final spring. This third spring is attached to the maxilla after the surgery, and this will hold the segment further, immobilized for a period of time, maybe 2 weeks and 3 weeks, that do not interfere with the patient's daily activity. Patient can still eat, can still wash her teeth after the surgery. And this is the case immediate, maybe 1 week after surgery, and the daily life activity can still be maintained, and also the oral hygiene care is still okay. And finally, a validation when we do the research or we do the outcome assessment to validate your postoperative result is important. And the common way is to superimpose the postoperative view with the 3D simulation view. And this is just a simple way using the color map to see how accurate is the maxilla mandible in between the plan and the actual postoperative image. So this superimposition also require a software to achieve. So to summarize my presentation today is that for the current 3D simulation for orthodontic surgery in my plan, I think we have these several steps that we could be very helpful in the practice. The 3D image data, we can use a dental model scanner or intraoral scanner. That we have this hardware, we have this facility in the lab, and then we perform the virtual surgery. We have several kind of software that could be used, and we can do the digital design and manufacturing and using the 3D printing. And for the personnel, certainly surgeon, orthodontist, clinical engineer, and assistant is important. So thank you for your listening, and I would be happy to answer the question.
Thank you, Professor Lo. And any questions from the attendants? I think it is a good revive and update of the 3D simulations. And Professor Lo is very unique. He is a surgeon, and he also do the surgical simulation by himself. So I think that he is the one that can reduce the gap between the surgical simulation and also the real surgical execution. And Dr. Lo, you have used 3 methods to transfer the 3D simulation to real surgical execution: occlusal splint, positional guide, and the navigation. But right now you really use the positional guide and navigation. And can you tell us the reason why? And do you think that in the future, what can be done to improve the surgical simulation by these 3D printing tools? Thank you.
Now I do not routinely use the positioning guide and navigation because it really takes time, and with with the help of uh the Facebook and extension bar, I think I can achieve the same accuracy without taking much painful time before the operation and during the operation. So that's the practice that if you find that your outcome can be similar, so then you do not need such complicated way. And I found that using the current practice, I can easily control my the facial bone in the right position before the fixation. And regarding the trend, I feel that really you have to do yourself. Then you find which part you can be further improved. And if there are any additional hardware, software you wish to have, and then we can figure out we can obtain that kind of facility. And anything that could improve the accuracy, improve the patient outcome, I think that was our further pursuit of this, either practice facility or anything. So again, I would like to emphasize the so-called the team approach. Is not only the surgeon or only the orthodontist. I think that there must be some interaction, communication between the whole team before you achieve the final plan.
Dr. Lo, can I ask some question?
Yes, Professor Liao, right?
Yeah. First, in your case presentation, you mentioned about the 7 millimeter advancement. Does this apply to all the cleft patient or just for this case? Because as I see, the case had a pharyngeal flap at the back. So the 7 millimeter advancement is for all the cleft or only just for this case?
I think the 7 millimeter is from the study of our orthodontic colleague before. That 7 millimeter it's a cut-off point, but certainly it's applied to all cleft and non-cleft cases, but maybe more important to cleft cases. If you find that advancement could be more restricted because of the soft tissue scarring. Certainly for some case you could do more than 7 millimeter if for very severe overjet patient, that negative overjet patient, that you need to mobilize the mandible very much forward, or the patient have some kind of sleep difficulty that you wish to mobilize the maxilla rather than retrude the mandible. Regarding the pharyngeal flap, if patient have pharyngeal flap during the surgery, I will look at how much could I advance the maxillary segment. If the maxillary segment is difficult to advance, I would not hesitate to divide the pharyngeal flap. And I always told patient before the surgery that it's possible that I need to divide your pharyngeal flap. But to my memory, majority of patients with pharyngeal flap do not require division of the flap during the operation or before the operation. So seems that with or without pharyngeal flap, the advancement of 7 millimeter it's not difficult in my practice.
Okay, thank you. And do you routinely resect the posterior part of the distal segment, distal to the ramus for the BSS or setback?
Yes, yes.
So-
For two reasons. One is to reduce the soft tissue resistance. The second is to divide the medial pterygoid muscle. Because my splitting is the obligator to pong technique is separated between the two cortex, not a different way, a different technique from the Professor Ray Chen. So I had to do additional posterior osteotomy to divide to reset the posterior part.
Oh. So how about sometimes we will find you resect the inferior part of the distal segment if the segment extrude or below the ramus.
Extrude.
Yeah, sometimes when you do the canting correction, sometimes do the extrusion, so the lower border of the distal segment will below the proximal segment. So do you resect
The posterior part? If the posterior part is backward protrusion, yes, I always remove the posterior part. Extrusion of the mandible to lengthen the mandible.
Yeah.
Is that what you mean? To
Yeah,
lengthen
yes.
the mandible?
Yes.
I will still feel that if there's any portion protruding or even not protruding, I still wish to detach the medial pterygoid muscle so that the distal segment will be more freely movable before the fixation. I think tension is important. I would certainly wish to, detach the muscle attachment surrounding the distal segment so that I could more freely mobilize without too much restriction or tension during the fixation. And this tension may cause the future relapse.
And finally, I'm interested in the extension bar. So can you explain more detail in how do you correct or check the midline or frontal occlusal plane using the extension bar?
Okay. In the design, the extension bar is put in the mid-sagittal plane. The midline extension bar has three dimensions: three horizontal, vertical, and AP dimension. And this AP bar will, protrude the extension bar from the mouth aperture. So you can easily observe the horizontal part, observe the vertical part, and this vertical part will be identical to the mid-sagittal plane in your 3D simulation. So this will define your midline. And because I use a Facebook, I define the Facebook before I do osteotomy. And then I will see where is my initial U1 position and where is my last U1 position. And this will use when I mobilize the segment, the bone, the extension bar will sit in the final position. So by evaluate the extension bar, horizontal, vertical, and also the pitch rotation, the patient lie on the operation table, and I draw the Frankfurt horizontal line, and I will look at the the so-called the reference bar for that verification. I'm not sure if I answer your question.
So we have to check with the Facebook together.
Yeah, I always use Facebook. Yes.
Okay. Okay, thank you.
And certainly, if the patient has abnormal ear canal or asymmetric ear canal, we do not use the extension bar. We do not use the Facebook, because the Facebook rely on the external ear canal.
Any other questions? It's a good discussion. And any question from surgeon? Dr. Zhang or Dr. Lu? 我看一下还有谁。
画面怎样转？这个画面
分享吗？
画面是分享。
Yeah, I think for the 3D printing applied on the surgical applications, I think we still have something can be improved, like the ramus part, the genioplasty, and hopefully that in the future we have a better way to transfer real surgical simulation to the surgical execution in this part. And thank you, Dr. Lo. And thank you for really nice and remarkable presentations. And for Mei-Jun, do you have things to announce?
No.
No, 好，那世谷呢？
Oh, thank you.
Okay, 好。If there's no further questions, we are going to close the meeting. And thank you for your participation. See you next in the September 5th. Yeah. Bye bye.
好，再见。